So in the next short while, I'm going to try and be practical and maybe to challenge some of you with your accepted practices. We'll see. But I'd just like to say before I begin, in my experience, I think that Onabot or Botox units are pretty close to Merz or Xiaoming, however you pronounce it, units. And mostly when I talk about units, because those are the two neurotoxins I've had most experience with, mostly I'll be talking about those units. And I'm afraid I still have a difficulty with converting Dysport units. Okay, so here are the first two laws of cosmetic botulinum toxin. The first, very simple. Where is the tip of the needle and how much effective botulinum toxin goes through it? There's nothing much else matters, really, is there? When you come right down to it, where is the tip of the needle? How much botulinum toxin goes through it? Second, when you're talking about reconstitution, and we've only been here a day and a half, and we've heard a lot about reconstitution. When you're talking about reconstitution, remember, dose is for the patient, dilution is for you. It's for your convenience. You happen to want to use this amount of fluid in the vial in order to give the concentration that you like to inject. But it's not got anything to do with the final result for the patient. It's purely dose that affects the result that the patient gets. So carrying on from that, what else don't I think makes much of a difference? Honestly, with botulinum toxin and with hand grenades, close is good enough. You don't have to get it exactly where you want. Of course, if you get it exactly where you want, you might get a higher dose there, and therefore you get a better result, which will last longer. But you don't have to worry about being too precise. And I particularly don't think that it makes much difference when you're talking about layers of muscle. We know that botulinum toxin will migrate through fascial sheets and so on. Ada Trindade, who is here, did work on foaming and shaking, showing that what Alan had put into the early product insert was really irrelevant. And we, in North America, almost everybody uses benzyl alcohol in preserved saline, but I guess it's not available in Brazil? Oh, and you're so unkind to your patients because the botulinum toxin stings. Why would you do that to your patient? 0.9 milligrams of benzyl alcohol is a kindness. As Jean has just mentioned, this is the law, L-O-R-E. Upper face is botulinum toxin and fillers, lower face is fillers and botulinum toxin. And when we're talking about how we use it, these are some of the areas which we commonly use botulinum toxin. And especially in the upper face, we tend to include this group of things. But I would ask you to abandon thinking about areas and think of the whole upper face, so that when you're looking at an individual, you don't just say, I'm going to treat the frown, or I'm going to treat the crow's feet, or I'm going to give her a brow lift, him or her a brow lift. Instead, look at them, analyze the way they're using their face, and then map out what is the right dose for them in each area. One of the other things I've been hearing about since we came here a day and a half ago, it's been a pretty active time, is how many patients do you treat from a vial? If you were to ask Jean or I how many patients we treat from a vial, there is no answer. How many vials to the patient, Jean says. The individual needs so many units. It might be 48 or 62 or 21 or whatever. That's the dose that you should give, not a third of a vial or a quarter of a vial or a half a vial. Let's just ask you a question. Here is a young female with a few relatively minor lines. Now here we're talking about German Botox units. Anyone give me a suggestion as to how much they'd put in this? Give me a total. Well, okay. This is what I would do, and in fact did do. You know, that there are a lot of young females who really don't need a high dose, and 5, 5, and 5 will give you a very nice result. Now, I've also, you might have noticed, put a little under the tail of the brow, and you can argue whether it should be 4 or 5, I don't know. This is a very common dose. Now, it's Botox light. You will need probably to redo her botulinum toxin every 2 to 3 months rather than every 3 to 4 months. But that's okay. This is very acceptable in an individual like this. So, and this is the result we got. And you can see from her platform here that she does indeed have a very nice eyebrow lift as a result of that. And of course, if she complains about this line up here, then you can put, and this would be a very common dose for me to use in the forehead. I'd probably inject a bit higher than it's noted here, but somewhere around about 10 units Botox or Xeomin units, and you get nice smoothing. What about an older female with significant lines? And this is the person who comes in and she says, my family are always saying to me, are you mad? And when they frown, they're really looking pretty mad. So I think in this kind of an individual, if you're not thinking somewhere up in the 30 to 40 unit range, you're not going to do a decent job. And the questions that you have to ask are, there we go. How far lateral are you going to inject? And are you going to treat the mid-pupillary line? So, for example, you might put something like 6 or 7 here, 10 units. Look at that great bunch of muscle there. You're not going to do any less than 10 units of Xeomin units or Botox units. And something up here. You have to inject somewhere out here, and we'll come back to that in just a second. Now, I should say, I'm talking here about a female brow, but I think that we really should be talking about brows that have more muscle, brows that have less muscle, and not be gender specific. I can tell you that in the Xeomin registration study, which was with 20 units, we had quite a few males who got a very good response with 20 units, which I wouldn't know, I will come on to, I don't believe in that. And then there are females like this who need much more. When Jean and I started injecting glabellas, we rapidly worked out that you had to inject this area. And people came back who could still frown, like this woman. And so I got out the EMG machine and we listened to where they were still able to contract muscle. And the answer is in the mid-pupillary line, right on the orbital rim. So, Jean and I injected half a dozen people right in the mid-pupillary line on the orbital rim, and Ada actually published on this, didn't you? How many cases of eyelid ptosis did you get? 2 out of 3 of 4. And I can tell you that we got, I think, 6 of 6 when we tried to do that. So that's why we started injecting up here, a sonometer above the orbital rim, in order to allow diffusion to come down. Remember our friend diffusion? Diffusion is your friend. Allow the neurotoxin to diffuse and get that muscle which is still working. I mean, look at the muscle that she's got here, the contraction. If you don't do that. But diffusion is not a respecter of gravity. It can go up, down, left, right, very happily. So there's absolutely no reason why you can't inject above the lateral canthus and allow it to diffuse medially rather than from above and allow it to diffuse down. Why is that? Okay, here's a 48-year-old woman, and she hated these lines on her forehead. It was her forehead that really bothered her when she came in. And I injected her as shown here. Can you all see that? Those units, once again, Xeomin or Botox units. So she comes back 2 weeks later. I hate it when this happens. Her eyes feel heavy. And you look at her and you say, maybe there's a little bit of something, but you know she's got eyebrow ptosis. Why does she have eyebrow ptosis? Anyone going to tell me? I'll tell you then. It's this little critter here. It's the injection in the mid-pupillary line that deactivated a significant amount of frontalis here and dropped her eyebrows. And that's why I have almost stopped injecting in this area, and now I'm much more likely to inject somewhere around here. Talk a little bit about filler. I think this is obvious. Okay, here's a question for you. If you have someone who comes in and he or she has deep lines in the glabella area, do you inject the filler the same day, or do you get them to come back? Same day? No, you get them to come back? You get them to come back. Why would you do that? Why deny them the pleasure? You know, if you put the filler in, it's going to look beautiful. And I don't know about you, but I tell my patients who come in with this kind of an issue, we're only going to have to put the filler in once. We put it in once, the first time I see you. After that, we maintain your Botox. You'll never need the filler again. And it's true. Anyway, this was our filler botulinum toxin study. Not these spectacular pictures. I mean, this is what people want. You take someone from that to that, they love you. And here are the results. Filler alone, the results really gone at 16 weeks, whereas the combination is still cooking along here at 32 weeks. Okay, let's talk a little bit about males. And I think it is impossible to overtreat the male glabella. And I tried. Here's our study. We had 4 groups, 20 males in each one, and they were injected in the glabella area with 20, 40, 60, or 80 units. And this is the result, just to cut to the chase. And you can see the yellow line is 20 units, really didn't work. It didn't get as good a result, and it didn't last as long. You see how it's wearing off more rapidly. And we got really good separation of these groups out to about 20 weeks. 24 weeks, you've got individuals dropping out, so that it gets a little bit fuzzy. All botulinum toxin studies are most significant up to about 20 weeks. Interestingly, in our female dose ranging study, we got a sort of plateau effect above 20 units. Whereas with the males, the more we put in, the more they liked it, and the bigger the smiles. There's not any significant increase in adverse events in the high dosage unit. We actually put the 80 unit group in there thinking that we'd get some adverse events. and we'd explore the upper regions of what's safe. We didn't get anywhere close to it. What we tend to do is to use a high dose on males initially to get the effect, and then titrate it down until you get a dose and a frequency that they're comfortable with. Males like twice yearly botulinum toxin, whereas females are more likely to be comfortable with 3 or 4 times a year. And with males, you must go lateral to reduce frowning. So you see, this is the area that I'm in. I think putting at least 10 units and maybe more out here in males, it gives you a much better result. But with males, beware of the eyebrows and use diffusion to soften the forehead. Here is one of the early males with horizontal forehead lines that I treated, and I actually used these as before and afters to show a good result in the early days. Did I do him a favor? No, I didn't. This is a dreadful result. And the question I would ask you is, would you rather go and have a beer with this guy or with this guy? It's pretty clear, isn't it? This looks terrible. So that's what happens when you knock out frontalis in a male to try and soften these lines. Don't do it. So you see someone like this who comes in and they want this fixed. The last thing you would think of doing is injecting along here. What you do is to give his glabella a real good whacking, and then see him in 2 weeks, and often diffusion, remember our friend diffusion, has done the job for you, and the brow is smooth, the line is gone. You may have to put a little bit up there, but surprisingly little. You might notice this little injection here, which helps to push up the northern end of this area of diffusion. Talking about diffusion, I hope you will agree with me that if we're injecting here above the orbital rim, typically we think we're injecting the frown, right? That's what I've been talking about for the past 15 minutes, so I hope you were awake. Whereas if you inject somewhere around about here at the junction of the temporal fusion line with the orbital rim, we talk about treating the brow depressors. And then you come down just a little bit and you're into crow's feet territory. We all agreed on that? Yeah? Does it matter? I really don't think it does. I think, remember, botulinum toxin and hand grenades, close is good enough. You can inject anywhere in this area and it'll do all 3. So don't worry about it. What, of course, we do worry about is if you treat as I used to do, glabella and crow's feet, leaving this area here, then you'll get this very attractive wrinkling of the lateral eyebrow area. I mean, it's easy to resolve, but you don't want to create a problem like this. So what I tend to do now is to stitch around orbicularis oculi, starting from the medial eyebrow, going right the way around into the crow's feet area, about every 2 centimeters. The lower eyelid, for the right individual, injecting the lower eyelid produces a spectacular result. Doesn't it look like she's lost about 20 pounds here? And yet, I don't know if you can read these little red numbers. These photographs were taken 2 weeks apart. And all that's happened is 2 units of Xeomin Botox units under the mid-pupillary line. And the way to do that is to see how she's looking up. She's lying down, she's looking up so as to tense her lower eyelid, and my finger is also tensing her lower eyelid. So again, stitching around orbicularis oculi, roughly 2 centimeter intervals, avoiding bruising by injecting superficially, be cautious with infraocular orbicularis oculi. And I think that this is the area where we're most likely to produce the frozen look. And anything we do to reduce expressivity is a bad thing. Jean talked about the brow lift, and I'm going to go straight by that. No, I'm not. Look at this day. That's week 4, week 8, week 12, and week 16. Let's see if I can go back. Oh, yes. So this is serial photography of a woman who was injected with 30 units of botulinum toxin into the glabella area only. So the most lateral injection was mid-pupillary line. And these are just serial pictures, and I'll read out the what's going on down here. But you just watch what happens to her eyebrows. So that's baseline. Day 7, the lateral at week 4, week 8, week 12, and week 16 is just starting to come down. Isn't that remarkable? We didn't know anything about that when we did this study. But of course, if you are increasing tone in frontalis, which is what produces the effect that you just saw in that semi-video, then that's how also you get the Spock eyebrow.